opinion using distilled water instead of dextran for swelling the cornea. Rajesh, would you have anything to say on that?
We used to do that long back, but now after we have the HPMC-based riboflavin, we achieve good swelling with using that riboflavin itself of over more than 100 microns.
Yeah, Dr. Raghav, welcome to the show and thank you for.
Good evening, everyone. Thank you so much for this opportunity. I am Dr. Raghav Malik. I will be speaking about combining cross-linking and laser vision correction procedures. So why do we need these why do we need to combine these two procedures? What about the patients who have the borderline topographies, who have that bad D, who have that CBI that is a bit abnormal? Are those patients not allowed refractive surgery at all? We may just have a solution. So we can combine LASIK, PRK, SMILE with cross-linking known as the extra procedures, while we can also do a PRK or PTK for keratoconus procedures, but we are just talking about the LASIK, PRK and SMILE in this session. So now we know that there is about 14 to 33% corneal weakening due to the flap creation. Once a flap is created, we know that the anterior stroma is cut along with the Bowman's. So that does not contribute to the strength of the cornea. So hence we need to add something else in addition to make the cornea strengthen after the procedures. Now, tissue subtraction along with vertical cuts that we make in SMILE and delaminating cuts we made in SMILE can make the cornea weaker. And this can lead to biomechanical instability and an ectasia can hence develop in future. So we need to keep an eye out for the preoperative high myopics or hyperopes, the thin corneas, the abnormal topographies, that is the FFKC, a patient who is prone to excessive eye rubbing or allergies, a patient who is pregnant or breastfeeding in the first 6 months, hormonal imbalances, and certain systemic and medicine that the patient is using. So now we know that a cornea which is cross-linked looks something like this, which is much stiffer than that which is not cross-linked. So the cross-linking restores strength to the cornea. It improves the flap bed adherence. That means that the flap does adhere much well to the stroma. There is a better tensile strength to the cornea, and the cross-linking reduces refractive regression and the risk of corneal ectasia. Apart from the biomechanical advantage, simultaneous cross-linking may also lead to less epithelial thickness increase, which is also implicated in regression. That is an additional advantage. So the concerns with cross-linking are that what about the safety? Does it have an effect on the refractive effect? What about the haze and scatter caused by the haze post cross-linking? And what about the long-term outcomes? Is there a progressive flattening? Who is the right candidate for a combined extra procedure? It is the younger patients who are the 18s and the 19s, the high myopic patients, the -9, -10, wanting a refractive procedure, high hyperopic patients, patients with a borderline topography, like I mentioned previously, bad D, the TBI, combining the biomechanical index, a patient with a family history of keratoconus, but himself or herself having a normal topography. And can we use this as a normogram for all patients? Now, this is a lovely flowchart given by Dr. Srigan and Dr. Brar. So this is a patient coming to your OPD where we have to consider the following criteria: the age, the spherical equivalent, if it is less than 10 diopters, the thinnest pachymetry, the residual stromal bed thickness, the biomechanical indices, the CBI and the TBI, and the contributory family history like a keratoconus or allergic eye disease. If no such factor is present, we can safely proceed for a PRK, SMILE, or a LASIK. But if any of these are present, 2 or more, age less than 30, spherical equivalent more than 6 diopters, a suspicious topography, but no clinical keratoconus, a thinnest pachymetry of less than 480 micron, a bed thickness of between 250 and 280, a bad D of more than 1.65, CBI more than 0.5, TBI more than 0.29, and a positive contributory history are the people we may consider for a combined extra procedure. Now, the riboflavin dye used is 0.25% concentration, and HPMC is replaced by Dextran. And Dextran is replaced by HBMC because Dextran may predispose to DLK. Now, this is how a LASIK extra procedure is done. We lift the flap immediately after the procedure. We put 0.25% riboflavin on the stromal bed, not on the flap. We let it soak for 60 seconds. And then we give UV radiation through the flap after thoroughly washing the dye off. We use a total of 2.7 joule per centimeter square energy and 30 millivolt per centimeter square for a total of 90 seconds. This is for LASIK extra. We see this is the demarcation line that we see in ASOCT. Again, why not through the flap? Because we avoid crossing the flap because it does not contribute to the biomechanical strength. Also, there could be flap shrinkage, which could lead to further issues like an epithelial growth. Now, these are many studies done that show that the higher refractive accuracy is found in patients with a refractive procedure combined with the cross-linking than with the refractive procedure alone. And there is no progressive flattening seen. This has been proved in literature. We see that patients with a combined LASIK extra showed no significant changes in the spherical equivalent over time, and they're comparable to LASIK only. The finite element model calculates displacement in residual bed when intraocular pressure is doubled. So if you see, when this is a patient where we combine cross-linking with LASIK, and if the pressure is doubled, the cornea is relatively flatter compared to a non-cross-linked cornea. So it has less displacement when IOP is increased in a thinner cornea, which is less stiff. The number of studies done till now on LASIK extra in myopia as well as hyperopia. So we see that most of them all have very good post-operative spherical equivalence, and more than 80% have BCVA of 20 by 20, irrespective of the haze caused by the cross-linking, which goes over time. And also the energy we are using is half that of normal cross-linking. That is very important. And also we have similar high and good results in LASIK extra with hyperopic patients in LASIK. LASIK extra is safe and effective. It has no refractive surprises, no loss of contrast sensitivity, no light scatter, and no increase in patient discomfort. PRK extra is for the borderline topography and with low thickness, for low powers, and for retreatments. The procedure, we divide the epithelium. After PRK is done with MMC, now we add 0.25% riboflavin for 90 seconds, and then the riboflavin is rinsed off, and then UV radiation of 18 milliwatt per centimeter square for a total of 2.5 minutes with a total energy of 2.7 joule per centimeter square is given, and a BCL is applied. This is a patient who has an asymmetric bow tie appearance with with an inferior steepening, with the elevation maps quite normal, and thickness 513. The BAD, we see that 2.57 BAD, and the PTI is almost borderline. So such a patient would be an ideal patient for a PRK extra. Similarly, the left eye had a BAD D of 3.4. So the patient underwent the PRK extra and was quite happy. Now, these are studies done on PRK extra. All patients had comparable refractive results post-op. SMILE extra, similar protocol is followed. 0.25% riboflavin is injected in the cap, in the pocket for 60 seconds, and then rinsed off, and UV radiation is given at 18 milliwatt per centimeter square for 90 seconds, delivering a total energy of 2.7. This is a short video of how how SMILE extra is performed. Immediately after SMILE is done, we inject dye inside the pocket. We leave it for about 60 seconds and then rinse it off, and then radiation is given for 90 seconds, and total energy of 2.7 is given. These are the studies given for SMILE extra. Dr. Ganesh did a very good study on SMILE extra, and he found that SMILE extra was safe and feasible and no complications were observed. So this is a case of a 21-year-old female, refraction of -5 with -0.5 cylinder, and similarly -5.5 and -0.5 cylinder, pachymetry of 536 and 537. BAD D in the right eye was 2.04, left eye 1.94. As you can see that the BAD D is in the yellow zone, and the CBI, that is the biomechanical strength, was normal, and the TBI was 0.12. Hence we proceeded with the SMILE extra, and patient did very well. So to conclude, results of this review suggest that combined refractive study with a simultaneous CXL is generally safe and effective in stabilizing refractive and keratometric outcomes in patients. It can expand the scope of corneal refractive surgery, especially for patients who have a borderline and a weak pre-op topography, pachymetry, and residual bed thickness. Longer-term studies are, of course, needed to see the safety. Refractive surgery with simultaneous crossing is not recognized as a standard of care. It is therefore essential to weigh the benefits and the risk with the patient.